Hi, everybody, and welcome to today's webinar. The title is Towards Better Health Systems, Preparedness and Response, Existing Gaps and Solutions. This is part of our series, Health Management in Action, Fostering Health Systems Resilience. It's a series brought to you by EMA, the European Health Management Association, and it's co-funded by the European Commission, so we thanks to them for that support. For today's session, we're joined by Professor Steve Thomas. Steve, thanks so much for being here with us. It's great to have you.
Great to be here. Thank you for inviting me.
Well, so Steve is, if I can go back to that slide to just explain that he is the Edward Kennedy Chair of Health Policy and Management and Director of Health Policy and Engagement for the School of Medicine in Trinity College in Dublin. He's Health Research Policy, Health Research Board Research Leader with the Restore program, focused on health system resilience and reform, which means he'll have a lot to draw from to speak to today's topic. How we'll use the time today is we have really a 5-minute welcome and introduction, which we're having right now. Then Steve will present on living with permacrisis, health system resilience into the next shock, with presented by Professor Steve Thomas. And then we'll have hopefully 15 minutes of Q&A, and we really welcome your questions today. So on to the next slide. Telling you a bit more about this series, and I know probably a number of you have been to several of these webinars already. It's really focusing on health management in action, so looking at fostering health system resilience, and we want to really discuss health management topics that are crucial to improve resilience, preparedness, and response. Now, this is brought to you by EMA, and for those of you who don't know us, our vision is excellent health management for a healthy Europe, and we do this by supporting the spread of knowledge on effective health management, and we really carefully want to always be living our values of excellence, quality, inclusiveness, relevance, and respect. So I hope you feel that and see that in everything you engage with from us. A few other things about EMA is that we are the only membership organisation in Europe that brings together the full diversity of the health management ecosystem. And we are a recognised and respected amplifier of best practices in the evolution of health management. And I hope that's what you're experiencing in this webinar today. And additionally, in this webinar, we want to provide an environment where evidence, challenge and experience are valued and complex debates on current topics can take place. So we do really welcome your questions, and you can put your questions into the chat, or even once Steve finishes his presentation, you're welcome to put your hand up and we can activate your camera, and we'd love to have a live engagement with you. So that's about EMA. And so now I'd like to hand back to Steve, and thanks again, Steve, for being here, and I hand over to you.
Great, thank you so much, George. It's lovely to be here, and thank you for inviting me. So I will now try and share my screen, hopefully, and let me know if you can see that. Can you see that?
In a moment, yep, there it is. We see it.
There we go. Very good. Very good. So thanks for inviting me so much today to talk about health system resilience. And I was just reflecting the other day when I was preparing for the presentation that actually a new word has come into the English language called permacrisis. And that's really the zeitgeist, the mood of the times that we are in. It's the thought that we just lurch from one crisis to the next, or maybe one crisis on top of the other. So we've got to get used to this. It reminded me of that famous tagline from Jaws 2, the movie, the sequel. Just when you thought it was safe to go back into the water, there's another shark. Just when you thought it was safe to go back to normal healthcare systems, here we are about to face another big shock. And so we'll talk about that. So how do we manage that? How do we respond to all of that and make the best of it? Okay, so I shall go to the next slide. Very good. So thinking a little bit today, I want to do a bit of revision about the shock cycle. What is it? Because that's basically where I'm coming from when I'm looking at health system resilience. The importance of recognizing where we are at the moment, so that COVID-19 is leaving a legacy behind. What is it? The expected part of its legacy and the unexpected part of its legacy. Learning also from the previous economic crisis, because it looks like we're about to head into another one. What is there out there that we need to think about? And then as we look and face into the next shock around the cost of living crisis and everything else, what are the kind of things that we need to do, taking into account all of this? Now I'll have some concluding thoughts, and so hopefully we'll then be able to kick off some discussion. And And I just want to say that, a lot of this is drawing on the research that we're doing with my Restore team, who I thanked on the first slide there, who are doing a great job. And I want a quick shout out to Paul Ulrich, Catherine, Ariana, and Liz for their helpful reviews also of what I'm going to say today. So thanks to them. Okay, so jumping in then. A couple of years ago, I did some work with the European Observatory, which came off the back of work with the Health System Performance Assessment Group in the EU, looking at health system resilience and starting to rethink it a little bit. A lot of the early focus was on absorption, adaptation, and transformation, but it struck us that actually this actually was incomplete. And it's much better to think about shocks as part of a sort of a whole dynamic shock cycle, which you can see over here on the left. So moving through the different stages from preparedness, getting ready for a shock, to when it hits, reacting to it quickly, responding to it. Then the shock impact and management, which is how do you deal with it, the main bit when a shock is happening. And then when it goes, what do you do afterwards? How do you recover from it? How do you learn from it? How do you deal with the legacy? And then you go through the cycle again. So in other words, a resilient health system is that which is able to manage well each stage of the shock cycle. And therefore, what you're doing at any one particular time to be resilient depends on where you are in the shock cycle. So that's one of the things that I want to come back to in a minute, and think about exactly where are we in the shock cycle, because that dictates how resilient we can be and what kind of responses we can draw on. And just to flag a recent systematic review that's just been published in Health Policy, where we look at the whole issue of measuring health system resilience in high-income countries over the last 20 years. And we come up with some key statistics in there, so I recommend you to kind of read that. It's quite an interesting piece. But one of the things that is very notable to me is when I look at the different focus of the research across those 2 decades, it's how uneven the focus is across the different stages of the shock cycle. And we can see this here with the chart on the left. So 52 out of the 64 articles were focusing on the management of the shock, so dealing with it when it's actually happening, so the absorption and the adaptation and transformation. Less are focused on some of the other sections, a fair bit on preparedness, although even with preparedness, there's often not a guarantee that you get things right in the shock itself. So you can think you're well prepared for a shock, but actually when it happens, that's not always the case. And we can see that with many high-income countries that thought they were very well prepared for a global pandemic, and they weren't. And then interestingly, the recovery and learnings bit of the phase is actually one of the least researched areas. So often people tend to move on after a shock, but actually a shock's profoundly change how society works, how health systems work, and it's important to pick up that particular issue, look at it closely and see how we've changed, because that's going to determine how our performance is going forward. So the question, where are we now in the shock cycle as we move into to the tail end of 2022? So we're really, I think, in this phase between stage 4 and stage 1. So we're just coming out of COVID. We're just trying to pick up the pieces again, trying to get things back to normal, and yet we have this new crisis on our doorsteps. So what the interesting point here, I think, is unless you do something, then your legacy from the previous shock will become your preparedness for the next shock. And there may be some good things in that, but there may be some bad things in that too. And I want to start to dig into that whole thing of what is the legacy that we have to deal with as we move from that stage 4 to stage 1. Now, some of it is very well known to you all. We've got high staff turnover. We can see here the top chart shows the staff turnover in Ireland for the health service executive over 4 years, and almost across all the areas we can see staff turnover increasing with the big R, the big resignation, as people are burnt out, they've had enough. So we have obviously a staff morale problem. Everybody knows that. We have waiting lists and we have backlogs of care because of people not presenting for care, or because of elective care being slowed down or cancelled or whatever. And the bottom chart here shows the total inpatient and day cases waiting in Ireland. And what we can see here is actually through the austerity period, the previous austerity period from 2008, it didn't increase that much, but it did afterwards. And it was just starting to come down when COVID hit, and now it's gone up again. So a big problem. How do we deal with that backlog of care? The third area that we all know about is the contested space for finance. Many countries have put money into the system to deal with COVID. Now what happens to that money? And there's a bit of a fight going on, isn't there, between can we keep that money for health and use it to deal with all the other issues, or is it going to get drained away into something else, or to do, you know, whatever that may be. So that's the kind of known legacy from COVID that we're all very familiar with. But I think there are some other issues too that we have to be aware of. One is governance muscle. I think actually we maybe think about ourselves as having kind of weak governance, weak muscle in this area, but actually, you know, I think what we've demonstrated through COVID, many countries have demonstrated quite decisive action, and that goes throughout the healthcare system at all levels. So we've had lockdowns and all kinds of emergency measures, but even down to facilities, there's all kind of innovative facility management that's occurred. You know, people making plans, choosing, you know, making different pathways for people with COVID and not COVID, and adapting to the whole situation and being creative. We also had a big uptake of telemedicine too, and that's often down to individual providers making things work. So I think there's an interesting way in which we've exercised our governance muscle throughout the system, and that's maybe something that we can build on. Also, at an international level, I think we've demonstrated quite a lot of good collaboration in Europe, whether that's surveillance, whether it's around procurement of vaccines and supplies. I mean, obviously, there's tensions where competition, you know, creeps in here, but there's been quite a lot of collaboration too, particularly as COVID has developed. I think there's issues around funding, making funding available to different countries at different times, even sharing some of our vaccine resources where people couldn't use it, or a general learning and sharing ethos, which again, I think could be a useful foundation for going forward into the next shock and into the sort of perma-crisis mode of dealing with whatever comes next. And the other thing I think is the key legacy from COVID-19, I think this is very interesting, is the exercise of very fast pressurized decision-making based on limited information. And this is a quote here that I've put up from one of our public sector managers that we interviewed for a recent report called the Presto report. And he said, once the emergency is over, I think the people who made an awful lot of right decisions will end up getting kicked up and down the street for the few they got wrong. And we needed them to be prepared to make a few wrong decisions in order to make decisions quickly enough. There is no criteria, however, that says you have to get everything right, because if you take long enough to be certain that the decisions you're making are right, you've taken too long. And so this has been the challenge, hasn't it, of making decisions fast decision making based on very limited information. And then when the new information comes along, you maybe find out that you made the wrong decision and you have to reverse it. So I think it's, and as we go into any new shock, we don't know the full parameters of it. We don't know the full effects of it. It will always be unseen effects. So we have to get used to, if you like, taking away some of the blame culture around decision making and making fast decisions. And even if you get it wrong, if new information comes, then you're able to change and reverse and go with it. So I think there's something about that muscle about fast decision making, which we've been forced to do as well, which could be quite useful for us in any shock environment going forward. Going back then to the previous economic crisis, we're just about to get a realist review published. It should be out in the next couple of weeks. And this really wanted to look at how, basically how, austerity impacted the health system workforce and impacted health system performance and resilience. And it's a very interesting review because we looked at all kinds of, across all different countries who went through this experience of austerity from the 2008 crisis. And we came up with basically these 5 themes. And I think that they give us a really good insight into what not to do this time around as we go to, as we go into another period of austerity. First of all, the whole issue of top-down governance. There was one of the things that came out was a real lack of ownership and buy-in from those delivering care, because they were told what to do. They became a bit distrustful about the decision-making agenda, about how austerity was ruling, and their own thoughts and considerations were marginalized. And so they were quite suspicious, particularly, if the Troika had an agenda here and there. So a real need for transparency, perhaps, in how some of the decisions are made, and maybe involvement too of health providers. There was also a perceived value shift in the last austerity period, whereby health providers thought that, well, the economics is taking over from me being actually able to deliver good care. And that was causing people to feel very demotivated, to be burnt out, to have a diminished view of their own profession, because they weren't really able to meet the high standards that they wanted to because of the austerity rules and regulations and the top-down governance. And this then led to health providers feeling powerless and detached and even resistant to change. So there's a whole issue about a resistance to change, but being told what to do and not being empowered, and so there's really negative issues coming through there, and this led in turn to 2 different things. There's quite a big strain on frontline workers that came out of this review about the literature across Europe and broader, and people were feeling real moral distress, and at the same time people started to do their own thing. So they started to sabotage policy by just ignoring the rules, or just by trying to game it to look after their patients. And in one sense, maybe that helped the patient outcomes. But in another sense, it probably led to the system being a bit chaotic and difficult and stressful. And so, so all kinds of different issues there. And the last thing that came through, and this sort of relates to the patients rather than the actual providers, was around health-seeking behaviour change. And of course, people were priced out of getting healthcare. We know that. We can see that from some of the utilisation data, where some of the costs went up, people put charges up. But also people seem to be less good at actually being able to navigate their way around the health system during austerity. There's a reduction in primary care usage, increasing use of emergency care when people should have been seen elsewhere, medication mismanagement or delayed treatment, people not taking the drugs when they needed to. Partly, some of that was cost related, but some of that was also some issues around health literacy as well. So there's quite a lot of warning signals there, I think, and lessons to be learned from that previous crisis and previous austerity that we need to take into this new crisis as we move forward. Okay, so now looking forward, what actually have we got to deal with? Because it's really important that we know what we're actually dealing with in the next shock as we enter it, because you don't want to bring a knife to a gunfight, and the problem with generals is they always fight the previous war. And this isn't a pandemic, it looks completely different. And actually, we've got quite a complex shock, haven't we, really? It's about the cost of living crisis that actually was in place even before Ukraine. There was some of the macroeconomic policies meant that there was going to be always upward pressure on some of the on inflation and some of the input costs. And we can see now, huge increases in fuel costs, problems of food shortages and fuel prices. Many countries will move into recession, maybe even stagflation too, maybe not, certainly increased inflation, certainly recession, perhaps I think employment will hold up. So it's not technically stagflation, but people are worried about that. And of course, on top of that, we've got refugees and migration, which is a huge thing, particularly in Ireland. There's all kind of debates now. Are we full? Are we not full? Can we cope with any more refugees? All this kind of stuff. And that's not coming from a populist point of view. It's just coming from a practical point of view. What are we going to do with these people? And then, of course, the war in Ukraine, which is the huge shadow over all of this. So my short reflections then on what to do around preparedness for this complex cost of living crisis would be 4 things. First of all, we need to think about the vulnerable. How do we protect the vulnerable? Well, we need to know who the vulnerable are. Can we introduce registries for people who are vulnerable to energy price hikes? Some of that may be just people who need to use a lot of energy. It may also be related to people who, you need to fuel the house, keep the house warm. So issues around fuel poverty and ill health. So can we understand who needs to be targeted, and can we do it? Secondly, can we protect health services and health facilities from cost hikes? So extra funds for energy, fuel, things like that. And that's not just the public sector, it's obviously the private contracted sector too. So in Ireland, we contract a lot of primary care with private GPs. What do GPs need to be able to make sure that their waiting rooms are warm, or to make sure that they can pay all their fuel costs too. So there may need to be special allowances that we organise for those private sector contractors who might get left out otherwise in the rush to sorting out the public sector. And one of the things that actually I was interested to learn about, another new word from the Collins Dictionary for this year is warm banks. And warm banks are public sector spaces which are deliberately kept warm to help people who otherwise can't afford to pay for their fuel costs. So maybe there'll be an added advantage to go and sitting in the waiting room now in the GP's surgery, that you get warm. Who knows? Anyway, thirdly, consider dropping access costs or implementing free care. We don't need our co-payments, our user fees, our access costs to go up at this time. We've already got a problem with backlog. We've already got a problem with waiting lists, and all kinds of things that may be undiagnosed. So we need to make sure we're not utilizing price increases as a way of rationing care. And of course, that includes migrants. And then finally, we need to beef up our information systems around austerity, because we don't always know what's going to happen, but we need to be able to respond quickly, as I said, in terms of fast decision making. And then, okay, so I'm coming up to the 20-minute mark here, so I won't take much more of your time. In terms of the concluding thoughts then, I think we need to get used to crises. We've just had a pandemic, maybe once in 100 years shock. But if you think about it, we've got a big economic crisis coming. We had a big economic crisis a few years back. Environmental shocks will start to pick up in severity and regularity. I think we have to get used to crises and thinking about how to cope with crisis mode. Now, on that basis, COVID has given us, I think, has allowed us to exercise our governance muscle, both on a national level and on an international level in terms of collaboration. And I think there may be some useful things to build on there. Hopefully, as EU countries, we can do that together. It's also given us good practice at high pressure, fast decision making. And we somehow need to help people make mistakes, help them have good information systems to support them, and to take a no blame kind of role, which is quite tricky when you have quite an open and transparent press, which is important. But at the same time, you have to move quickly on some of these things, particularly where when we're into where lives are at risk. Previous austerity didn't really protect human resources. So we have to think about how we can do that better. How can we be open about the challenges that we have, open about decision making, honest with them, co-create values. So if we're going into a period of austerity, how do we agree what we will and won't do so we don't just get people gaming the system? And how do we create trust there, particularly where people are burnt out? So there may be an interesting focus there. And then I think in terms of the next crisis, thinking carefully about, it is going to be a crisis that's, around the economy, around a lack of resources, both on the public side and on the household side. So how can we utilize the resources we've got well to protect the vulnerable, to protect access back into the health system, and to make sure that our providers can keep operating and providing quality care? So I think that's probably me done. There's just a few references. The systematic review, a couple of other papers, the observatory report. There's the website link where the realist review will be shortly, and there'll be other information as well about the Irish case of COVID and analysing that. And which just leaves me to say thank you very much for your time, and I'm looking forward very much to our discussions.
Thank you, Steve. That was really fantastic. I really enjoyed that. I felt fully engaged, and really appreciate you presenting today.
Great, pleasure.
It really, I was texting colleagues saying this webinar is triggering. Like, it's so precise. I even just tweeted about it saying that it's just to have someone so perfectly, accurately, kindly and beautifully describe what's happening in our systems right now. It was, for me, quite triggering. So I'd like to turn to the audience and say, I really would encourage you to ask your questions if you have anything you'd like to know more about. I certainly have several questions, so I'll jump in with them, but I do encourage others. Steve, the first question I'll bring to you is, you talked about the war in Ukraine, and you contextualized that well for us. We also have several members at Emma who are involved in military health. So, because as you would understand, the health systems of the military are completely separate, usually, to the civilian systems. And so we've got also the health and well-being of military personnel as another separate group, but also then thinking about how all this comes together. Does that come up at all in the work you've looked at?
Thanks, that's a good question. I'm sure there's a lot to learn from military health too. It doesn't come up so much typically in the literature in high income countries. So we've only really, in the systematic review, the only thing that was picked up was the sort of Balkans conflict. So it doesn't get such a high focus. But of course, in the low and middle income literature, there's certainly loads, particularly on conflict affected areas. So yes, it is there. It's not sort of a high income country thing so much, but it certainly is there. And there's quite a lot written around Lebanon and migration as well. So there are there's the two things, isn't there? There's actually conflict affected areas, and how do you keep a health system just functioning in that setting, or where it's gone, how do you kind of set it up again? So there's that set of issues which is there in the literature, and there's also the stuff which is like the knock-on effects for the countries impacted who are around the conflict-affected area. How do you deal with migration? And so, places like the Lebanon, it's obviously a big thing there.
And so some of the things you pointed to, as well as about reconsidering the financing of health systems, like, these are obviously points that everybody in this room would agree with, and health managers at large would be saying that that's important. Have you, through the research, have you seen any of the willingness of governments and funders to move that way?
I mean, what was interesting really is, we all agree, and we all say, oh yes, that's really important. Yes, of course we have to do that. But actually, when the gloves come off, when the priorities are there and resources are being squeezed, it's amazing who gets what values and principles get thrown aside, which I think is why it's really important to have that discussion now. And what was interesting was how often during the previous financial crisis, the cost sharing came out, was full and prevalent. I mean, I have to give the Irish government credit for this. As it's moved out of COVID, it is trying to implement this large reform program, Launch Care, to bring universal healthcare to Ireland, which hasn't had it previously. It is trying to roll out free GP care because that hasn't been in place. So it is trying to use some of those COVID resources. And rather than being lost to the health sector, is trying to then utilize them to make sure that we provide some protection for households. But that's obviously a very contested space, and I know that the budget negotiations went right down to the wire on that particular point. So I think there is some evidence there, but obviously there's going to be a lot of pressure for competing use of those scarce funds.
Yeah, indeed. And like we hear a lot of discussion about engagement with the Recovery and Resilience Facility from the Commission. And we've also heard about countries reducing their funding to healthcare. And so for us, as we're looking forward, it's difficult to see how this might be trending across Europe and what to expect for the next few years.
I mean, I think one of the strongest arguments is that actually when the health system doesn't work, as we've seen during COVID, everything falls apart. And so I think there's a very strong rationale to keep pushing that agenda. And even when countries themselves are losing that fight at a European level, to keep pushing that agenda. Actually, this is the fabric. If this goes wrong, your economy will go wrong too. It's not a trade-off here.
So on that note, I wanted to ask you then around, I like that statement you said of when health goes wrong, everything goes wrong. And one of the things that I'd like to get some better literacy on is around working with groups who do not well connect to the health system, groups who might be disadvantaged. So you framed well about the need to address their needs. And I wonder, could you say a bit more about that in a way of, I don't mean that there'll be people who disagree, but I mean, I think people might be struggling on why we keep raising that as a focus. And others might say, well, we provide a health system and it's open to everyone who needs it, or however we define that. And when we keep saying, well, you really should be looking at some particular groups, people sometimes think, yeah, but maybe not. You can see I'm struggling to even ask the question because I don't want to politicize it. I don't mean it in that way.
No, that's fine. I mean, I think the issue is, you can have a healthcare system which looks like it's a level playing field, but it depends where people start, doesn't it? So is your system really universal, and who gets in and who doesn't get in? Who is able, if you've got a home address, that's a good start point. If you haven't got a home address, it's amazing how difficult it is to access healthcare. If you don't, if you can't receive things through the post, or you haven't got an email, or whatever it is. So I think the issues around disadvantage and how do you make a system truly universal, that yes, it's not a quick fix thing. And I don't think, I mean, we had a very interesting, in fact, colleagues of mine have done an interesting case study around the traveller community in Ireland, and saying even, their access to healthcare was not good during COVID, despite efforts. And it's almost like, it was almost too late by the time the shock hit, because then you couldn't get things in place that should have been in place a while back. So I agree, it's a tricky issue. But I think if there's a certain amount of disadvantage and a lack of infrastructure or facility support, or even responsiveness of the system to those disadvantages, then there are obvious gaps, and it's not going to work for them. I mean, it's the old adage, who benefits the most from a universal healthcare system? It's the middle class. They do best, and maybe that's okay because they pay for it. But yeah, there are, I think, quite critical issues around vertical equity, and therefore I think a lot of work needs to be done getting inside the lived experience of such groups to understand how you make a system universal.
Yeah, indeed. Okay, so that also has me thinking about areas of rurality, and I know that at the moment there's been a lot of work happening on medical deserts and defining them and understanding them, and where they might fit within the work. Do we need to be thinking even more differently about medical deserts and rurality?
I don't know. I don't know that literature so well. I know what we have a very interesting postcode lottery in Ireland about, if you live 10 meters that way, you might get these services. If you live over the border of that county, you won't in that area. So, I mean, there are obviously key issues there. But actually, I mean, strangely enough, we have those problems less in Ireland, because actually rural Ireland is quite nice and people quite like to live there, and it's away from the congested cities. So I'm probably not helping your point.
Well, but I think it reflects a lot of the geography of the rest of Central Europe. We see these things replicating, in, like for me from Greece, like there's a similar kind of layout. I think Bulgaria, I think, many countries have that too. And like I've followed in the literature on the medical deserts work, that they're, even in small countries like the Netherlands, they can define medical deserts. So I think the thinking applies. I see a question from Evelyn in the chat. Evelyn Donahoe says, can you speak to the idea of proportionate universalism for healthcare access and the benefit this might have for healthcare equity?
Okay, define proportionate universalism.
Evelyn, you're welcome to activate your camera and your mic if you're...
Hi, yes, can you hear me?
Yes.
We hear you.
Yes, so proportionate universalism, it's a concept developed by Michael Marmot in the UK. So it's basically the idea where it's not trickle down, so to speak. It's more that services are invested in the communities that need them most, but it's based on material need rather than material and social needs. So if I'm living, sorry, I'm from Ireland, so you can probably tell by the accent, but if I'm living in Sandymount, which is one of the richest areas in Dublin, then technically they should get less services than Ballymun, which is one of the more disadvantaged areas of Dublin. So in this case,
okay. That's fine. I mean, I think there's a lot of sense in that from a technical point of view of targeting your resources. I think it comes back to the issue, though, as soon as you disenfranchise the middle class, you remove the people's willingness to pay, because they're the people who pay. And if you don't get them paying for it, then you get things tend to go private. And people say, well, there's no point in me paying my tax because I'm really not getting this stuff. So I shall go and buy my private insurance, and I shall go and go. So I think there's obviously truth in it from a technical point of view, but I think you have to watch the political realities of it, because you need everyone in the basket rather than it just being a pro-poor system. And that's quite a common theme in some of the literature from low and middle income countries, is that pro-poor systems tend to be poor quality. So I think there's a balancing act there, but I can see what you're saying, but there's definitely there's a feasibility issue.
Great, thanks for your question, Evelyn. I see another question in the chat from Annette Rosanov. My question is related to what you discussed just now, rural areas, medical deserts. How do you see finding a solution to health workforce shortages? What would be needed for being ready to welcome and integrate carers from third countries, which could be one of the obvious solutions?
I mean, that's a minefield of a question, isn't it?
Yeah.
Because all kinds of ethical issues. Should we take people from abroad? Should we not? What I mean, and there are loads of issues covered in the WHO global code about which countries should I be able to take health professionals from. So the Philippines oversupplies nurses because they want you to take them, and that's quite different from taking them from Malawi when there aren't enough. But then there are also issues around rights. So putting all that aside, it can be obviously a quick fix, but there are issues around whether it absolves each country from taking on sufficient responsibility for their own training and funding that properly, or whether they're just going to poach people, if I can use that pejorative term, from other countries. And certainly some countries, and Ireland would be one of them, and UK would be another, rely on a lot of immigration. Now, if it's handled well, and there are good relationships and agreements, it can be okay, but it often isn't.
Okay, so we're coming towards the end of our time. We've got room for another couple of questions. The one that stays with me, Steve, is around the term permacrisis. And I like the framing of that. I think it's important to be shifting our way of our expectations in the work. And I wonder, like, if in the future we'll get to a point where we don't even use permacrisis, we just say, this is the work, like this is the job.
Yeah, and I mean, one of the interesting strands in the resilience literature is to say the health system is always in crisis, and every day is a big crisis, particularly for some managers in some areas. It's just one thing after another. So there is a way in which maybe some people are already thinking in that way. I don't quite agree with that yet, but I think there are severe challenges, because I think these shocks do add a different dynamic in. But yes, I think if you look at the sort of progression of the last few years, it seems there are more and more things happening more and more quickly. So things are coming to a head, if you like.
Well, because separate to COVID, even before that, Emma's been doing a body of work on health system disruption. And one of the topics we've looked at is the seasonal disruption of RSV, which is a lower respiratory infection, largely presenting in children. And we see it impacting annually in health systems, usually from November to January. We expect, well, March, in fact, we expect to see health systems, especially pediatric care, but even emergency care and primary care being completely overwhelmed by that. And so we've had that situation for decades.
Yeah.
And then there's several other things that we see doing that. And obviously COVID was exceptional, but also HIV was exceptional, and viral hepatitis or hepatitis C was very differently profiled, but also exceptional. And when I think of, I mean, I've worked a lot in infectious diseases, I just keep seeing another cycle of, now we have monkeypox, of course,
yes.
Presenting itself. So, and so then maybe to reframe my question is, we've seen the restructure of DigiSanté into a One Health model and thinking more about global health. And does thinking about that present itself in the literature of a need to really readjust our focal points, especially as you described, flexing the
Sure.
governance muscle?
Sure. I mean, and I think, we're living in the globalized world and interconnected as we are. And as we get more and more interconnected, having a global view is clearly more and more important, and not just thinking about Fortress Europe, or because you can't do that. You can't contain, as we've just seen with COVID, as we see with all these different crises. And who would have thought, when I first arrived in Ireland in 2005, who'd have thought they'd have been taken over by the IMF? So I think, oh my goodness, that not meant to happen, is it? So I think having that approach of, where is the largest need, where should we be targeting our resources, because there's spillover effects for everybody else. There are contagion effects, literally, as well as figuratively. So indeed, I think we're all going to have to get into that frame of mind. And also, I think some of the environmental challenges too are forcing us to think more and more on a global level.
Okay, so maybe to finish off, Annette added another great question, which is, we've lived through a financial crisis, COVID crisis, now an energy crisis. She's asking you to predict the future of which big crisis do you see coming, which will once again challenge health system resilience?
Yeah, all of the above, but all at the same time. I think it's more concurrent shocks. So we have this idea, and that's actually one of the issues in the shock cycle, is it sort of says there's one thing and then you get ready for another thing and then that happens. But I actually think it's more like the layering of shocks on top of each other. I think that's what we're going to see.
Well, okay. I mean, that's an interesting note to finish on, but quite a relevant one. Steve, it's truly been fascinating for me. We've got a couple of slides to finish off. One of my colleagues will put a link right now into the chat, and we just ask you to fill in a really short evaluation. As I say every week, it takes more time for me to describe it than it will take you to fill it out. And it's like 3 questions about how you found today. And really the engagement in these surveys really help us to pick good quality content, great speakers like Steve today. So, so please do just spend 90 seconds filling that in. And then otherwise, I just want to tell you about, we have our 9th webinar in the series next week, which is the legacy of COVID. It'll be on Monday, the 7th of November. So if you're not already registered, do hop onto our website and make sure you're there. I saw in the previous slide, I always get my prompts wrong. Sorry, Anna, who's behind the scenes doing the slides. To encourage you to be an Emma member. If you're not already an Emma member, do join. It's our members who really do help really shape this content. So that's it. I've mentioned, I think, all the right things. I want to say thank you. And Steve, to you again, I just want to say this has been fascinating. And I'm so pleased that you were available for us today. And thanks for your great work and sharing it.
Thanks very much. It's been my pleasure.
And thank you to the audience. We will see you all at the next webinar or some other place. Take care, everybody.